Welcome back. As you know, PTAC will issue a report to the Secretary of HHS that will describe our key findings from this public meeting on identifying a pathway towards maximizing participation in population-based total cost of care models. We now have time for the committee to reflect on what we have learned from our sessions today. We will hear from more experts tomorrow, but want to take the time to gather our thoughts now before adjourning for the day. Committee members, I'm going to ask you to find the potential topics for deliberation document. It's tucked in the left front pocket of your binder. To indicate that you have a comment, please flip your name tent or raise your hand in Zoom. I also just want to alert you, as we have in the past, I'm going to go around the circle to have everyone add in what were your key takeaways from today. We for sure want to capture for the report to the secretary, or remaining questions that you're hoping that we get to tomorrow. So would anyone like to start? Who would like to start? Angelo, please go ahead.
First of all, I thought it was a fantastic day. All of the groups and panels were just amazing, and clearly had a lot of expertise and a lot of experience. Today was kind of a culmination of things I think we've heard over the last couple of years as we've talked about various things, but it was nice to see it packaged in a particular way that kind of drove where we think we need to go. Some major areas of focus that I heard about, again, are things that we've talked about, but just heard it in a different way. One was data, and not just raw data, and maybe having access to that raw data, but being given that data in a way that actually provides information to the practices so that they understand how to manage their patients and also understand how well they're doing. The other thing that was talked about today was measures, simplifying measures, developing fewer measures, and creating standard definitions across Medicare, but also all payers. Developing fewer models out there, too many opportunities to participate in too many different models, and is there a way to rationalize those models to fewer models? Heard some comments around being wary of downside risk directly to physicians. And although we've talked about that a lot, I think there were some good cases made today about not maybe giving direct positive rewards, but not moving the downside risk directly to the docs. Also, paying attention to the beneficiary needs, and are we measuring that, and how are we incentivizing activities for the beneficiaries to participate? Heard again today some comments about team-based care from several people and how important that was, and how maybe in the future we could create a model that helps pay for team-based care. Then also heard a lot of discussion around benchmarking and particularly comments about avoid ratcheting, which obviously occurs today. So those weren't all inclusive, but those were things that quickly came to my mind after the end of the day today. And so I thought those were important things that needed to be highlighted. So.
Thank you, Angelo. I'd like to go to Larry and Josh next, so we make sure that we don't miss you since you're virtual. Who would like to go first?
Josh,
Larry, you're off mute. Please go ahead.
All right, I'll go. I was making my notes, but since you pushed us up earlier, I'll do it. What I heard, we don't all hear the same things, I guess, but what I heard was we need to coordinate the business success drivers with the population health needs. And that applies to the health system, it applies to the practice, and it also applies to the beneficiary. And we need to use simple methods with actionable data to help us accomplish that. That was my major takeaway. The second one is we still have a problem with the specialists. We can do bundles and episodes, but we still have this big issue lurking out there. What do we do with the cognitive care model for specialists, and they're the ones that are taking care of the most complex, costly patients we have out there. I jotted down a lot of good sayings. I love one. Michael said it. Post-acute care is the ATM for ACOs. I love that line. I may make a slide out of that. But we heard over and over again. It's got to be actionable. It's got to be simple. It's got to be implementable. And we're in an era of hybrid models as well, and we've got to utilize existing structures to try to help the specialists become part of the solution. So I'm sure if I have a chance to go through my notes, I have more, but that's what I've got right now.
That was great, Larry. Thanks. Josh, please go ahead.
Yeah, thanks. A couple key takeaways and a couple tension points that I'd love to look forward to teasing out maybe tomorrow or in future meetings. The first is kind of predictability and certainty, the sense of, when it's not predictable or you do everything right and the outcome is unpredictable. I think that being problematic, that was something that shone through for me. And the second, maybe more importantly, was kind of this idea of rewarding success generously. And I could see it three kind of subcomponents of that. One is model design. So you heard Ratchet, like, one every 2.5 speakers. So Ratchet is a model design issue. But there's another issue, which is just the size of incentive. I think Zeke said it the most kind of directly, 1 or 2, 3% versus 10, 20, 30%. And then kind of like the impedance on whatever side that is, meaning if you rely on conveners, they play a very important role, but they suck up a lot of that incentive, right? So even if you increase the size, you only get that slice, right? So there's some model design, there's just the money you pump in, and then there's like the ways in which you make most of it transmit to the clinicians and the groups that are delivering care. And there are a lot of ways to think about that. I think, democratizing and flattening data being one, creating financial buffers. There's a lot of things we can talk about more, but that idea of rewarding success generously, to say it simply, to put an incentive on people participating, I think is relevant. The third thing, I know a few of our SMEs try to stay away from this very thoughtfully, but I think Mike Chernu's point is the right one, which is that no choice is made in a vacuum. You make a choice about an APM or a population-based TCOC model alongside MA or any other model out there. And so everything I just said about predictability, certainty, the generosity with which we reward success, to me, has to be taken alongside those other things. Even if we're thinking about models directly, you can't ignore the environment there. We ignore it at our peril. So I think that would be those three comments I have. A couple of tensions I don't know what to do with, that just me kind of putting it out there for the committee is, I heard kind of themes around, we want simplicity, we want fewer, we want rational. And yet I heard kind of ripples of another, what I would call side of it, which is, but we need it to be tailored, need to be like relevant, and, we need to give people a choice. And, I find those are sometimes not always directly aligned. You can create a clinical integrated network. It can be large, it can cover everybody, and then you will not have as many options, right? So do you want simple, streamlined, rational, or do you want more options that are smaller? One more example, then I'll stop. We talk about not having too many models, and I tend to agree with having fewer rational models. And yet I don't know which edge of the blade we're on. If you give more groups, more types of models with different parameters, does that increase their participation? And if you cone it down to 2 or 3 very large models, are we sure that's going to increase participation or decrease? I don't know. It's an open question that I don't know anybody can answer. So we just need to balance a few of those things that I heard, I think.
So key. Thank you, Josh. Jay, please go ahead.
So on the theme of keeping it simple, we hear over and over and over again at every meeting, and for my tenure here, we've got to pay primary care physicians and providers more, period. End of story. All we're going to debate is how to get them the money and how much. And I think we heard today, it needs to be consequential. It can't be a small bonus. It's not going to change behavior. So we need to focus on that. And then an area that I find very interesting, and I will disagree with some of our esteemed experts that we had this morning, is how do we handle social determinants of health? The panel this morning seemed to feel, well, if we really take care of healthcare costs, we'll have more money to spend on social determinants of health or spend it better. I'm kind of on the other side of the chicken egg here, that I think if we spend more and figure out how to pay more for social determinants of health, we'll have less healthcare expenditures.
Excellent. Thank you. Ginny, please go ahead.
Fantastic day, I thought. Just lots of diverse opinions and some surprising ones. So, first, I'd like to start with something that threaded through the entire day, and that was democratizing and standardizing data. Nothing new to us. We've heard this now for years. However, I think the thing that is really important is that the ask that CMS take the lead in that, and having data, the ability to standardize and syndicate data not be expensive, because one person, two person, or rural practices just can't afford that. And so I think that's just an important point. The other thing that I found somewhat surprising is the ask that incentives not necessarily be passed down at the provider level, and measurement, like quality measurement, be done at the clinic level. I'm not sure I agree with that entirely, but I do appreciate that it's nuanced, and that when you do translate incentives down to the provider level, you have to be very careful. And I think the ask for flexibility in the ACO to do that is important. So the last thing that was said in the day, and I'll kind of say, was simplicity, flexibility, and things that enable provider and not to forget the beneficiary. I thought that was a really important point that came out towards the end of the day, that beneficiary adoption is important. So let's look at the cost of the beneficiary. Let's look at what they're looking at as well, not leave them out of this sort of realignment. And then the last thing that, I found to be somewhat really important that surfaced up is just a reminder that MA and ACO are not comparable because they're funded very differently. And we often look at MA and say, gosh, they're getting to all these things and look at all their benefits and we should be able to just do that. And I think that it's important to remember and be reminded of consistently that the funding mechanism is different. So if we can't fix the funding mechanism, then we have to be cautious in comparing the two.
So helpful. Thank you, Ginny. Jim, would you like to go next?
I'm going to just focus on one part that has not been said, I think. And I wanted to just amplify something that Larry said. The physician-provider enterprise must succeed to match capacity to the population health needs. And there was a comment by one of our speakers around the mismatch over the next 20 years, I suppose, between the capacity of the provider community and the population demand needs, right? And also demand. And then there was this discussion around the idea that we overpay and underpay at our own peril. And so from a charting of our, let's say, the recommendations to the secretary, it seems to me that that might really be a part of the, the front end of everything we're going to talk about. All the things we want to say is about that, because we, as the provider representatives of the provider community, are that's our opportunity to have a voice into the public conversation about the policy prioritization, so that capacity we don't find ourselves 20 years from now when I'm 87 that we don't have enough capacity, and I've chosen to live in a particular geography where the capacity to get specialty care is limited to a telehealth visit because the migration to the urban area, it is significant. And so I thought I'd just elevate that and get that into the discussion.
Thank you, Jim. Lee, would you like to go next?
Love to. Similar to Jim, I'm just going to focus on, I got so many pages of notes, it would take me hours to try to draw pearls out of that, but some key points that I certainly heard. Of course, data, ever-present topic. I did hear something almost even a little bit more advanced. What we've heard is we need not just a data utility, data infrastructure where the data is the lifeblood moving through the system, but that the models and the payers sponsoring value-based care, the ACOs, the enablement companies need to be more proactive, more aggressive in doing analytics, serving it to the doctors as actionable intelligence. Right now, models typically say, we make our data available, do with it what you will. We're hearing, and I've experienced this over 15 years, that is it's not even close to sufficient, right? That alone is a barrier that would make most non-huge high revenue groups just pass. Secondly, I think I heard as clearly as I'd ever heard before that complexity is just out of control and out of hand. And that is reflected multiple different ways. But essentially, I heard from these experts, essentially a plea, stop releasing more models. Pick one. It will tweak, it will evolve, it will adapt, it will get better. It will not be perfect when you start, but just pick a couple of horses and let's ride them. Stop with the models, which I thought was interesting. And then I appreciated the focus on beneficiaries a little bit differently than what we've had. I heard two different things. One was I appreciated the attention, the highlighting that we often focus on the fee for service versus MA dichotomy. One is just flat Medicare, you pay your 20%, you see whoever you want, you don't get any coordination. It's just, open range. And MA brings all these extra benefits and coordinates it, and there's financing mechanisms to fix. But this tweak in the middle, that's 40% of fee for service have a med sub, that they're paying much more out of pocket, but actually they're not getting any of the additional benefits, the coordination. Those companies that want to coordinate, if the fee for service beneficiary has a med sup and they're in an ACO that provides care management, that goes to cost basis, not medical costs. That was a really interesting tweak. I think is pretty important that seems amenable to some policy changes. And then lastly, I heard, and I'm not sure how I feel about it yet, but I heard someone at the end say essentially that focusing on beneficiary choice or beneficiary incentives was the wrong question, because beneficiaries choose their physician. And if you build a system that the physicians are successful in and lets them take better care of their patients, the beneficiaries get what they want. They get the access, they get the communication, they get the coordination, and it all works out fine. And that was interesting.
Thank you, Lee. And Lindsay.
Well, I guess this goes to, you can hear the same thing and take away different things. So I think what I heard in the conversation around beneficiaries is certainly a call that we should look from the lens of the beneficiary as we think about payment models and where we need to be. I heard conflicting things today as to whether incentives make sense and whether it truly is sufficient to just get the doctor that they want. So I think there's questions to be answered around how can savings be shared with beneficiaries? What is it that beneficiaries want and need? And probably some of those result in why beneficiaries are making choices to get us up or go to MA or other choices being made. So I know this is a conversation we're already thinking about as a committee, and hearing multiple different panels touch on it today, I think just confirms we need to probe more.
So helpful. Walter.
Great day. Learned a lot, and I'll look forward to another exciting day tomorrow. Just taking a step back, right? So the theme of this two-day public meeting is around essentially identifying a glide path toward the goal of achieving 100% beneficiary in an accountable relationship by 2030. And I think the very first panelist, or our very first panel, called that, I guess, big dot goal into question, right? So my big dot takeaway from this today's meeting was perhaps there should be some other definitions of success along this journey to value-based care besides just 100% participation. But regardless, though, I think that's going to be one element. There might be other elements that hopefully will come out in our continued discussions and even perhaps tomorrow. Along this journey, though, I thought the panelists raised a lot of great points in terms of what might be hindering some beneficiaries and providers from participating in total cost of care models. And just to kind of highlight some of the things that have been already mentioned, risk adjustment is one big issue, right? I think one of our panelists put it very bluntly and said HCC is broken. And if we were to redesign a risk adjustment system today, it would not be using old fee-for-service claims data. And there would be a much smarter way to do that. Looking at, for example, frailty. I heard that mentioned a couple times, and perhaps I'm sensitive to that because of our June meeting, which a lot of our subject matter experts talked about frailty and functional status and cognitive status in helping with risk adjustment. But the other kind of similar thought along those lines was there's no way of moving forward along this glide path without revaluing some fee-for-service codes. I thought that was great to hear because that's kind of been my own experience as well at the bedside and working with other clinicians who build these codes. I think Tim Ferriss mentioned that, gave the example that initial visit is 10 times the work of a follow-up visit, and yet it's paid just a little bit more. And there are some other kind of examples along the way. I'm glad to see CMS, CMMI moving in that direction with codes like the Advanced Primary Care code that was discussed during the CMS panel session. But I think those kind of codes are going to help lubricate some of these friction points that have slowed the glide path.
Thank you, Walter and Jen.
So many wonderful points and a really excellent day. I think the only other comments I would add in is going back to the phenomenal analysis that my colleagues and NORC did, reframing for us who are the population of patients that we're talking about and what has been the impact to date. And again, really, I think rich data that's going to have a lot of impact from a health policy and care delivery perspective. And I continue to be struck by the fact that nearly 50% of all Medicare beneficiaries are in Medicare Advantage plans, which as juxtaposed to those who are in traditional Medicare. And yet there's only 30% or less of provider payments that are being made in this APM space. So back to the points made around a goal of 100% accountable care relationships by 2023, thinking about reframing the goal may be important. And I like Dr. Ferris's question around who's responsible for creating or who's accountable for creating capacity. And the simple math that if the unit cost is more than payment and participation is voluntary, then we have a supply and demand mismatch. So who's responsible for fixing that and for which population, regardless of ultimately then payment? And I thought it was interesting that Dr. Chen said, as painful, I think I wrote this down correctly as a quote, as painful as it was good that CJR was mandatory. Again, back to the comments that we've made previously around voluntary versus involuntary being a big dot mover. And then two other subpoints that I would make is this comment around a consideration that risk adjustment benchmark goals should consider some rate that is commensurate with inflation and thinking about, what is total cost when we think at the 100,000-foot view. What does success look like? And I also heard a comment around maybe future risk adjustment methodologies being more sophisticated using LLMs. And that sounded to me like a real opportunity for industry innovation for us to think better about how to leverage big data to be more meaningful to create benchmarks.
Thank you, Jen. And I will add just a couple of quick comments. So as we look at all payer models and integration and heading towards total cost of care, there were a couple of themes that stood out to me. So one is a universal need to address health equity and looking at payment rates and also upfront investments for building the infrastructure to address the complexity on the table. The second is health-related social needs and how universally amongst payment models, it's important to have a flow of how that's addressed. And three key themes that are emerging as part of that. One is nutrition, the second is transportation, and the third is housing. And then the other key theme, as much as we definitely have universal desire to have primary care that we trust, the other theme of longitudinal care management and that relationship and the opportunity to engage beneficiaries in a partnership to really participate in their care and that importance of having an integrator to bring everything together. So we've had a fantastic day. I want to acknowledge the PCDT group for the excellent presentation that they began this meeting with, as well as the research and articulation from ASPE and NORC, and all of our panelists. We've had excellent dialogue today. I want to thank everyone for participating and also for all of you who are listening in. We will be back tomorrow at 9 a.m. Eastern Time. Our two-day agenda will feature three amazing listening sessions. Our first listening session will focus on organizational structure, payment, and financial incentives for supporting accountable care relationships. The second listening session will focus on developing a balanced portfolio of performance measures for population-based total cost of care models. And the third listening session will address challenges regarding data, benchmarking, and risk adjustment. There will also be an opportunity for public comment tomorrow afternoon before the meeting is concluded with committee discussion. We hope you will join us then. Thank you, and the meeting is adjourned for the day.
Produced by the U.S. Department of Health and Human Services.